Hello, I'm William White, a professor from the University of Connecticut School of Medicine, and today I'm going to talk about quick tips to manage resistant hypertension. These are my disclosures. Resistant hypertension is defined as blood pressure that remains above 130/80 in spite of concurrent use of 3 antihypertensive agents of different classes. Now, ideally, one of the 3 agents should be a diuretic, and all the other agents should be prescribed at optimal dose amounts. Resistant hypertension also includes patients who require 4 or more medications to establish blood pressure control. Predictors of a lack of blood pressure control, such as demographics and clinical characteristics, include black race, target organ disease such as left ventricular hypertrophy and chronic kidney disease, female gender, obesity, and older age. It's important to exclude pseudo-resistance in the evaluation of treatment-resistant hypertension. First, it's important to ensure accurate office blood pressure measurements using a validated device. Secondly, we must assess adherence to the prescribed antihypertensive regimen. And finally, it's important to determine whether the blood pressure in the office represents blood pressures elsewhere and that there is not a white coat effect. I like doing this personally by using ambulatory blood pressure readings over the day and night. It turns out that white coat hypertension as a form of resistant hypertension persists even with repeated visits to the doctor's office. This study from Europe demonstrated that in a nice way, showing that even after 1 year to 18 months, about half the patients with white coat effect persisted despite their familiarity with the medical care environment. So the only way to really rule out white coat effect is with ambulatory blood pressure recordings. Secondly, we like to discontinue or minimize interfering substances that interfere primarily with antihypertensive drug therapy. A classic example of this are the nonsteroidal anti-inflammatory drugs, or NSAIDs, that are usually prescribed to treat either chronic pain or arthritis. These drugs particularly interfere with renin-angiotensin blocking drugs because they induce volume retention. Stimulants that may be used for psychiatric disorders, sleep disordered breathing, and so forth also can cause an excess in blood pressure. Oral contraceptives, licorice, ephedrine, ephedra also can do that to a lesser extent. Importantly, when patients present with resistant hypertension, we must rule out secondary forms. These are the big 5 in this particular slide that cause hypertension that's resistant to treatment: primary aldosteronism, chronic kidney disease, particularly when the GFR is below 60, renal artery stenosis, which can actually be either fibromuscular dysplasia, which is rare, or more commonly atherosclerosis, pheochromocytoma, a rare endocrine tumor, which is in fact very symptomatic in most individuals, and commonly obstructive sleep apnea, which affects nocturnal blood pressures and induces resistance from that end. The prevalence of primary aldosteronism is by far the most common form of resistant hypertension. About 20% of individuals tested in a variety of studies have demonstrated that primary aldo was present in individuals with treatment-resistant hypertension. The way this would be screened is by obtaining a serum aldosterone and a plasma renin activity along with electrolytes in individuals with resistant hypertension. Importantly, you need to recognize that some drugs interfere with renin, perhaps increasing it or decreasing it, particularly the beta blockers, which decrease the renin activity and may give you a false positive ratio. Refractory fluid retention is also associated with resistant hypertension from these various syndromes, including hyperaldosteronism, obesity, chronic kidney disease, African American race, particularly with high salt intake, and just high dietary salt intake. An example of this is the study from Pimenta et al. From the University of Alabama, who evaluated a small number of treatment-resistant hypertensive patients with either a high or low dietary salt intake over a period of a couple of weeks. Patients were first randomized to either one of the conditions, washed out, and then treated with the opposite condition. This slide demonstrates the changes in blood pressure going from the high salt ingestion to the low salt ingestion. It was really quite remarkable. The office blood pressures went down by 23 over 9 millimeters of mercury, and using ambulatory blood pressure measurements, they determined that the daytime and nighttime values went down by 20 over 10. This is really a remarkable impact in a highly resistant population in the Southeast United States. When it comes to pharmacological treatment of treatment-resistant hypertension, there are some caveats. First, we should maximize diuretic therapy, and as I'll show you in a minute, use more chlorothalidone than hydrochlorothiazide. Sometimes it's very effective to add a mineralocorticoid receptor antagonist. When different agents are used with different mechanisms of action, it's important that they're complementary. For example, an ACE inhibitor with a diuretic, or an angiotensin receptor blocker with a calcium channel blocker, whereas drugs like alpha-2 agonists such as clonidine, in addition to an alpha-1 blocker such as prazosin or doxazosin, is not a very good combination. And then finally, when patients have chronic kidney disease or are receiving potent vasodilator drugs such as minoxidil, it's important that we consider using loop diuretics to rid the excess volume. This is a slide that describes the differences between hydrochlorothiazide and chlorothalidone. Chlorothalidone and hydrochlorothiazide are both very old diuretics, and when I started practice, chlorothalidone was used very widely. But because of hypokalemia and concerns of arrhythmias, it fell off our radar. Subsequently, years have passed, and now chlorothalidone at lower doses have been shown to be very effective, particularly when they're combined with a renin-angiotensin blocking drug. Chlorothalidone has a much longer half-life than hydrochlorothiazide. Its duration is at least 1 day, if not longer. And as was shown by Michael Ernst years ago from the University of Iowa, when using chlorothalidone 25 milligrams versus hydrochlorothiazide 50, the changes in 24-hour blood pressure clearly favor the chlorothalidone. And this is most prominent at night. These are the changes in nighttime or nocturnal blood pressure, showing that patients who are randomized to receive chlorothalidone had about 13.5 millimeter reduction in systolic blood pressure versus 6.5 on the hydrochlorothiazide. So this long duration of action and the excessive volume was really quite effective in treating hypertension at night. Another choice, of course, is spironolactone, in which the volume excess and the fact that possibly some patients do have underlying primary aldosteronism would have a greater impact by spironolactone than other kinds of drugs. This particular study, which is one of many, showed the impact of spironolactone versus ACE inhibitors or ARBs in patients with true resistant hypertension. You'll note the clinic blood pressure as well as the 24-hour ambulatory blood pressure fell much more substantially on spironolactone than it did on an ACE inhibitor or an ARB. So in general, from the guidelines that we have produced over the years, spironolactone is a treatment choice for individuals who are already on 3 drugs and still have uncontrolled hypertension. Now, sometimes it's very frustrating to treat patients with resistant hypertension, and I would advocate that you consider sending your patients to an appropriate specialist in your region who might have a lot of expertise at working up secondary forms of hypertension or just have a great deal of experience in these kinds of hard-to-manage patients. There are not that many sort of tried and true hypertension specialists in the United States. There's a couple thousand, but they are probably in most every state in the country. So I would suggest that consideration of treating patients, or referring patients, I should say, to a hypertension specialist might be in that patient's best interest. Thanks very much for listening today. Goodbye.